Okay, good afternoon. Thank you very much for that kind invite. I have two declarations. So I am an Epic user. I've been using for 5 years now, and it's 24 hours and 36 minutes since I last used. So my other declaration is, so I will use in this presentation really as an example some work that we've done with a small UK AI company called Tortoise. We do, as a hospital, have the tiniest share option in that company, so it's worthwhile acknowledging that. So what is AI? So we think of intelligence really as that ability to solve a problem. If it's artificial, a machine's doing it. We have those probably, there are many more concepts than this, but you can clearly define it as sort of what we describe as narrow AI. So I'll come on to some examples of that, but I would have that as something that categorizes something. There's a dot on a chest X-ray, a machine can detect the dot. General AI, that's this more broader sense. Now, we see some of this with the large language models, but it's that bringing together, in my mind, of data that then enables us to predict something. And I don't think we're quite there with that. So why do we want to do it? So lots and lots of positives. I've given some X-ray examples there, but if you look at mammography, so in the UK, 2 radiologists report a mammogram. You can clearly see from the AI data you only need 1, and then the person to check. But actually, probably the data suggests you don't need any, dare I say. But we'll have to get there, won't we? But it's very interesting that those sorts of characterization things and classification things are there. Our patients are using it. All of our phones have some AI app now, don't they? So they're using it to support. And increasingly what we're seeing is, actually, can we use these algorithms to define how a flow in a hospital works, how our clinical utility works, so on and so forth? Like everybody else, I'm going to be very sloppy. So actually, as one of the speakers said this morning, this isn't anything new in one funny sense, but I kind of broadly call these things clever computing, because it starts with statistical analysis, which we'll all do, machine learning, and AI. I'm going to be as sloppy as everybody else and not really define which it is today. There are problems, though, aren't there? So if you're like me and you like these sorts of films and you lived in the world that was Ready Player One, actually going into that artificial world was probably quite nice. However, if you're more minded than Terminator with the robots taking over the world, you're going to be slightly anxious about all this stuff. And I jest not. So somebody holds a meeting in our organization. A person from South America, actually, I think Peru, is invited along. That person turns on an AI bot on their computer because they want the minutes of the meeting to be automatically created for them. Unbeknownst to that person, that AI bot populates that person's diary and invites the AI bot to every subsequent meeting. The next meeting happens. The person doesn't turn up. Unbeknownst to the chair, the AI bot turns up, though. Halfway through the meeting, a picture of every person is presented to the screen with a summary of what they've said. Everybody in the room's going, what the, where's? The person who took the minutes went, yes. But it was complete shock. Actually, it's this thing of, now we've got a policy, turn your camera on first, you can turn it off later. But it's very, very interesting. Check your people list. But these things can happen. Here's a summary. So this is just about hallucinations. So this is a consultant of ours who's coming for an interview, and they want to work out how you can use MRI systems efficiently. So they go and query one of the well-known large language models. Gives a completely set of reasonable suggestions. They want to be more specific, and they say, there is a paper by Cutty for this particular congenital heart disease, okay, tetralogy of Fallot. Could you identify this paper? That's the paper it comes up with. This is not a paper. You probably guessed, because there's year in brackets, it's not listed there. This does not exist at all. It appears you have invented a paper. Okay, oh yes, I'm so sorry, this is the real paper. This is not a paper. These two people, interestingly, work together, so it's getting closer. This doesn't exist. And there was a whole summary of what you would do with tetralogy of Fallot. It's just made up, completely, not exist. This is the paper she was trying to find. So it's really interesting. We have to be very, very careful. So these hallucinations are things that cause people concern. And then this final one, and we touched on this around gender, is actually we've got to be very, very careful about now, biases can be good and bad. I'm going to pick a bad one here. We've got to be careful about in our innate historical biases. So this is a recruitment AI tool that's designed. It looks at previous CVs, which you can see have usually had men put into those jobs. Lo and behold, it doesn't shortlist any women. This is not good. Okay, So as we were going through this, clearly some of the things that vex us about AI are some of the things that we work towards, though there are lots and lots of positives. So in our own organization, we kind of went through some principles. And we've mentioned one of them, but I don't think it's necessarily, it was mentioned earlier, I don't think it's necessarily a overly cautious note. But we kind of use the Hippocratic Oath and Asimov's 3 laws of robotics, and we came up with these 3 things. So do no harm. Make sure what you're doing has equity and confidentiality. And for us, at this point in time in our journey, there must always be human supervision. We've then got a set of principles that we came up with, which are really around being patient-centered, making sure we've got evaluations, cybersecurity, bias-free, as I've alluded to, data protection, so on and so forth. But those are some of the principles that we can adhere to. So as an example, we were approached by an AI company. It was fundamentally a chat bot that would talk to people before they came into hospital, but would triage them. There was no human involved. So we said, no, thank you, we don't want to work with you at the moment. That may change, but at the moment, those are the sorts of things that we put in. So what about the real-world use of clinical data or for AI? So we know huge investment. This slide shows almost nothing in healthcare currently. You might think there's lots, but there isn't. I guess there's a lot in apps, which people have personally, and very little in life science. And all of that money is going to that tiny little red box. Okay? How we develop the sexy bit. How do I develop a really cool tool that's going to solve things? Now, this morning, we talked about everything to the left of that slide. You've got to have your data in place. But actually, we've got a whole new world going forward of how we implement these things. So if you think in the past, you bought some software, your ICT department looked at that software, they sweated the asset for 10 years, but it didn't really change. You're now going to put in an algorithm that might be 95% accurate on day 1, and 86% accurate on day 2. Whose decision is that in any of our systems to say, well, that's not good enough, we need to do something else? So there's a lot of things for us kind of to think about in that implementation piece, and I think that's the bit from hospitals we can really drive that forward. So what are those infrastructures? So we've talked about getting the data, so that's your electronic patient record, crucial in many of this, but then to use that data for these algorithms, how are we going to, what is the infrastructure in a hospital to deploy it? What are the financial models? If you look in the UK at the moment, if you think about ICT, we buy computers, so we have it on-prem. How do you pay for the cloud? It's revenue and capital. How do you deal with those issues? It's really difficult. Who's responsible to validate and monitor? And actually, how do we disclose? So I write a report. Do I say, I don't say, I'll tell you, I read the following radiology books that made me, and I have the following experience for every report I write. But might I now have to say, oh, actually, I use the following AI algorithm? Or conversely, a patient might come and go, why didn't you use this AI algorithm to make this better? So these are all things, new things that we'll need to think about. And probably, or certainly in our own hospital, what we currently have is really almost data chaos, not quite, but not far off. And so though there's lots of direction, particularly in the NHS for this, and as we've heard today in Ireland, to make this happen, there aren't really currently the infrastructure pieces available to do that. So here's a use case. I'm going to make you all a little bit sad here. So one of the disadvantages of electronic patient records, so great for people who do research, because suddenly you've got this wealth of structural data. Your clinical teams really do not like putting lots and lots of data in. It's really boring, it's really cumbersome, it's the one thing people don't like. And so we did this study which really looked at sort of the burnout that is associated with electronic patient records. And the use case model that we thought of using here was actually how can we get over some of that? And the model we chose was actually if we look at our outpatient letter, so you have a clinic appointment and you need to write a letter. Sometimes that can take a long time to do, and the letter has to go off for dictation. It can be a couple of weeks before a patient's receiving that information back. Also, in most outpatients now, it's me talking, typing, talking, typing. It's not really that patient-clinician interaction that we once probably wanted or held. So we work with this company called Tortoise, and this is fundamentally an ambient technology that then links into a large language model or a set of large language models to create instantaneously a record of your conversation with the patient as an outpatient letter. So you turn that on, it listens, you don't type, you leave it alone, and it will automatically create that. I guess the other super advantage of that is it can potentially pick up terms that it can then enter into the EPIC record. So as well as doing your letter, you're then going to be asked to do the problem list. Actually, if I can just have my letter created and my problem list extracted from the letter automatically and put into something like EPIC, that is great. Again, I've saved a cumbersome waste of time task. So how can we do that? So we've taken this sort of 4-phase approach, tried to do it a little bit like a drug trial. So it's an 18-month relationship. First 2 months, we worked in a sandbox for phase 1. Let's build a minimum viable product that will work in a pediatric hospital at Great Ormond Street. Phase 2, so let's do an experiment here where we give actors a script, which we do which is very realistic, with 48 clinicians and see how this model then works. And then we'll do phase 3, which is 200 patients and 200 outpatient settings, so the real patients and the real clinicians. So these are the phase 2 results. So this is sometimes a bit hard to say, but so we used a tool called SAIL, which looked at the quality of the outpatient letter created and the note created. So we've just spent £40 million on EPIC, and the quality of our letters is 43%. But it gets better if you use something like this. And that's just about people and how they interact in conversations. You can see that both for the note and for the quality of the quality of the letter. Also slightly controversial, we reduced the time. So actually, the face-to-face time was the same, but the overall clinic time was 25% less. Now, this is an artificial setting. That might not work in all of our clinical practice, but you might expect some reduction in time. So you might be able to see more patients. It's kinder. All of the people said, this is a much better interaction. I am not talking to somebody who's typing on a computer. And for us, it's safer because these things could be entered in. So we then worked with NHS England to say, actually, this is really interesting technology. In a weird way, I'm not interested in who does it, but what I'm very interested in is, we've just done this in a pediatric hospital. How do I now scale that so that I'm doing it in an adult hospital, a mental health, or does it work in an adult hospital, community care, mental health, general practice, ambulance services? So we have a year project now, which we're halfway through, funded by NHS England in the London region to try and do this. So we've done this with Kingston Hospital, we've done it with a North West London primary care setting. That is a really interesting thing. So they do a lot of telephone. It's a practice that has probably about 45% of its population speaks Punjabi. Most of its general practice speaks Punjabi. They do lots and lots of teleclinics, as it were. And what they said to us is, it's impossible to listen to that conversation and type at the same time. So they record every conversation. So they have to go back to every conversation and then type it in English. So we ran each one of those through this particular algorithm, and instantaneously that record of that telephone conversation is in their clinical record without them having to translate, saving them, again, a mundane task that was needed to be done. London Ambulance Service. What happens at your ambulance? You have this rich conversation, and at the door, 95-year-old man with a stroke. There's so much more information that could be brought across. So how do we begin to do that? So that's what this next phase of it is about. As ever with any AI, so we're used to having platform costs, maintenance costs, but there are these other costs. Like, think of it as the fuel, APIs, and so on and so forth. So it's just something to think about. So what have we learned? So as everybody has said, and we did this very, very carefully at the beginning of this, the patients are crucial to this. The governance is interesting. R&D departments aren't used to dealing with these sorts of projects. So we have created our own committee, actually, which is the Data Partnership Committee, which has our Data Protection Officer, our Caldecott Guardian, and then all of our IOs, as you've described. And data security, anonymization, all of those things are really, really important. They have to be at the center of it. Come up with some sort of guidelines that you want. Data is crucial. So we've been on this journey, and similar to SEGAR, we have something called our data research environment. So that is really crucial to how you get that out. And though we started off with that, we've seen, as we've moved through the years, how that data foundation has been absolutely crucial to everything we do. You need something to monitor. If it was 95% today, is it 95% tomorrow? And you need to monitor. My analogy here would be like a lab test. I run a potassium of 4 every day through the labs, and the lab test comes back with a 4, and if not. And as everybody has said, collaborate, collaborate, collaborate. There are so many ways and so many people to do that with. So our solution to this is probably to create something like this. Like you have a lab medicine department, in the future, will we see these sort of departments of clinical analytics? Thank you very much.